Now, in anesthesia, there are generally two reasons we're using a nerve stimulator. Reason number one is we want to assess muscle relaxation when we've given a muscle relaxant to our patient. Reason number two is to help with needle placement during regional anesthesia, to help us make sure our needle is in the right place before we inject the local anesthetic. Today we're just going to focus on the first one, assessing muscle relaxation when we give a neuromuscular blocking agent. Now, in very simple terms, your motor neurons run on electricity and they stimulate the muscle fibers to contract. Therefore, if we apply an external electrical stimulus, then we can induce a muscle contraction. What happens at this junction, in simple terms, is you have little vesicles of acetylcholine, which when an impulse comes down the nerve, releases these vesicles, and the acetylcholine molecules flood into the synaptic cleft, and they hit these receptors. These are nicotinic acetylcholine receptors on the muscle, and they bind to the receptor and they induce a muscle contraction. Now, if we give a muscle relaxant, such as suxamethonium or rocuronium, we block these receptors and we prevent the acetylcholine from inducing that muscle contraction. The electrical impulse will still come down the nerve and the acetylcholine will still be released, it just can't do anything when it gets to the muscle. And as a result, you get profound muscle relaxation. These muscles cannot function. However, for evolutionarily obvious reasons, you need to block a lot of these receptors before you get any clinical weakness or muscle relaxation. So you need 75% of the receptors to be blocked before you will see noticeable clinical weakness. Now don't worry, this is very much temporary, and if we just wait enough time, this muscle relaxation will wear off. If you've given rocuronium, it'll be metabolized by the liver and excreted in the bile and the urine. If you've given atracurium, it'll just break down by itself. So eventually your patient's muscle strength will come back to normal, but that doesn't make for a very efficient theatre list, so it's nice to be able to monitor just how relaxed they are and potentially reverse the relaxation at the end of the operation if we need to. So a nerve stimulator helps us determine how relaxed the muscle tissue is and whether or not it is suitable for us to give a reversal agent. So that's where we need our peripheral nerve stimulator. Here's my drawing, and here's a real one. As you can see, it's a simple box device, has a couple of batteries in it and a couple of electrodes. So what does it do? Well, you will pop some sticky ECG dots somewhere on the body, preferably near a nerve, and you'll put the red one close to the nerve and the black one somewhere else. And then you're going to push one of these buttons. And what do? This will give an electrical stimulus through the wires and therefore will apply a current to the nerve that you have attached them to. And any muscles that that nerve is attached to will then receive an electrical stimulus, and if they're not blocked, they'll contract, and if they are blocked, they won't. These different modes refer to different ways of giving an electrical impulse that give you different information. First of all, we have the milliamp current here. Now, the threshold for generating a muscle contraction is about 50 to 60 milliamps, generally speaking. And we want our machine to make sure it's giving a supramaximal stimulus, meaning more than that, so that we're definitely going to recruit all the nerves that we can, and we're going to recruit as much muscle tissue as possible. And we'll start with TOF, or train of 4. If we use this incredibly complex graph of twitch size over time, what train of 4 does is it applies, as the name would suggest, 4 sequential impulses at a regular interval. The interval is half a second, meaning the frequency is 2 Hertz. And what we're going to do is apply these stimuli and then see how much of a muscle twitch we actually get. If you've just given a big dose of muscle relaxant and then you do this, you will get no response whatsoever. So you'll hear your machine making its noises as it gives the impulses, and you will see no muscle contraction whatsoever. Meanwhile, if you were being really unkind and doing this to a fully awake patient who had received no medications, you would get 4 large, equal twitches. And this is where it gets interesting. If you give suxamethonium, what you'll start to see as it wears off is you'll go from no twitches at all back up to full twitch size, and they'll all be the same size. You'll get 4 equal twitches, and the size of the twitch will depend on how much of the muscle relaxation has worn off. But with rocuronium, it's different. What rocuronium does is not only does it block these receptors here, but it also blocks presynaptic receptors as well. And then these receptors, what they normally do is they act as a bit of positive feedback. So when acetylcholine binds to these receptors, they encourage the release of more acetylcholine, which kind of makes sense. If you've had one muscle contraction, it's likely another one is coming, and it might be important, like running away from a predator. So it makes sense to have some receptors help boost the amount of acetylcholine being released so that subsequent muscle contractions are stronger. Now, if you block these receptors, like rocuronium does, you're going to get less acetylcholine released on subsequent impulses, which means the next one will be weaker than the previous one. So what we see with rocuronium is a concept called fade, which means we might have an impulse that's fairly big to start with, but then subsequent ones will get smaller and smaller over time. So while with suxamethonium, we have to simply just go off the twitch size to see whether there's residual reversal or not. With rocuronium, we also get this fade component. So what will start to happen as rocuronium begins to wear off is we'll see a first twitch to begin with, but we might not see any more because it's coming back to this kind of height, but the second impulse is still too small to detect. And then as the reversal wears off, you will get increasing number of twitches visible. So if you have one twitch visible, that means 90% of your receptors are blocked. 2 twitches means about 80% are still blocked. 3 twitches is 75%, and 4 twitches just means that fewer than 75% are blocked. Like we said earlier, we need 75% of the receptors to be blocked before we see any significant weakness. If we see 4 strong twitches after rocuronium has been given, it just means that now fewer than 75% of the receptors are still blocked. So you could still have more than half of your receptors full of rocuronium, and therefore there may be some degree of weakness that is not immediately clinically apparent, but you don't know about this because your twitching is telling you that you've got 4 strong twitches. So that's the key thing, is to remember that even if you have 4 strong twitches after you've given rocuronium, that means you could still have up to 75% of your receptors blocked with rocuronium. Now, this might not be an issue. If you've got a fit, healthy young patient, they might be absolutely fine and breathe just fine by themselves. And then, like we said before, over time, that relaxation will continue to wear off and they'll return back to normal. But if someone has got poor respiratory function for whatever reason, or has got other drugs on board that might make them feel weak or drowsy, that residual weakness could be an issue. So you can't just twitch, get 4 twitches and assume that you don't need to do anything about it. So that's what this TOF button means. If you press that, you can hear it giving 4 beats at a frequency of 2 Hz, and it's just going to test that fade for rocuronium or a single level twitch height for suxamethonium. What about DBS? DBS stands for double burst stimulation. As the name would suggest, double burst stimulation gives 2 bursts of stimulation of 50 Hz each, and these are separated by 750 milliseconds. This is essentially a much more crude version of train of 4, and what it'll do is it'll give a bigger sustained impulse further apart, and the idea is that this is more sensitive at detecting fade. So you might do 4 twitches with TOF and get what you think are 4 equal sized twitches. However, if you then do double burst, you might find that the first one is quite big and the second one is substantially smaller. And this will tell you there is still a degree of fade and therefore quite substantial muscle relaxation still on board. Whereas with train of 4, you might not detect that fade. So it's a more sensitive way of detecting fade than train of 4. And the last one we'll talk about is tetany. Tetany will give a sustained burst of stimulation 50 to 100 Hz for up to 5 seconds. And the idea is that this is going to give a huge stimulus into your neuromuscular junction and release lots and lots of acetylcholine. And it is likely you will release enough acetylcholine that even with quite a lot of neuromuscular blockade still on board, you'll get some sort of twitch that was not visible either with DBS or with train of 4 because not enough stimulation was being applied. So tetanus or tetany essentially applies so much stimulation, you flood enough acetylcholine into the synaptic cleft, it competes with the rocuronium and produces a bit of a muscle twitch. Now this extra acetylcholine is going to hang around for a minute, so it might be that if you then apply train of 4 immediately after doing tetany, you might then see a muscle twitch that you didn't see before. This is called post-tetanic facilitation, which means if you apply another stimulus, a single stimulus or train of 4, immediately or within 2 minutes of doing a tetanic stimulation, you may then see some twitches become apparent that you didn't see before because there was not enough acetylcholine in the junction to compete with the rocuronium. This is your post-tetanic count, i.e. you give a tetanic stimulus and then you apply train of 4 or just single impulses, and you count how many twitches you can now see having given a tetanus stimulation. And the post-tetanic count will give you information about a patient who's still got quite a lot of muscle relaxation on board. So it's useful if you want your patient deeply relaxed for high-stakes surgery like neurosurgery, where you really don't want them to move. And to give you an idea of just how much the tetanus influences how visible these twitches are, a post-tetanic count of 15, so seeing 15 twitches after a tetany stimulus, is approximately the same as just seeing 2 twitches on a normal train of 4. And that is the magic number for giving reversal. If you're reversing with neostigmine, you want to see at least 2 twitches on your train of 4 before neostigmine is going to do a good enough job of reversal. If you're using Sigamadex, it's slightly different because you just adjust the dose. If you've got no twitches and you've given the rocuronium very recently, it's 16 milligrams per kilogram, which is a very expensive dose of Sigamadex. If you can see 2 twitches, then you can give 2 milligrams per kilogram. And if you can only see 1 twitch, then you want to give 4 milligrams per kilogram. But it's the 2 twitches on train of 4, that is your threshold for conventional reversal, or when you can use 2 milligrams per kilo of Sigamadex. So those are the main things you need to know about peripheral nerve stimulators when assessing muscle relaxation. You're assessing how many of these receptors are still occupied by rocuronium. The crucial thing to remember is you need more than 75% of your receptors blocked before you see any clinical weakness. And the main modes to know about are train of 4, double burst, and tetany with post-tetanic facilitation or post-tetanic count.